So we do have both chat function and Q&A function available. If there's stuff that you want to say informally in the chat, please do that, as I've said, but also do use the Q&A function, and I will try and capture as many of those as I can when we get to the formal Q&A session a little bit later. For R, who is going to be speaking after me, I would just remind you that she's appearing anonymously this morning, so her video will be off. She's a migrant survivor of domestic abuse based in London, now committed to campaigning and activism as a result of her experiences. I want to say thank you before we begin to our advisory group, to the specialist by and for organisations reflecting specific issues in health, London and domestic abuse concerning race, sexuality, gender identity, immigration, disability, all of these things that we know intersect for people and can create additional barriers and issues which aren't being addressed as well as they might be to help people get the support that they need as quickly as they need it. And I want to say a big thank you to the survivors who took part in the process of developing this report. Many of them, some of whom may be here in the session today. And we do always work from a process of know them and us at SafeLives. So even if somebody here isn't here formally and disclosed as a survivor, then we value and we honour and respect your experiences. Many people on the call today will have their own experiences of domestic abuse, and we always treat that as part of the conversation. So just before I hand over to our migrant survivor, I just want to leave you with 3 starting thoughts. One is that being trauma informed can sound like a kind of scary concept, but can be really simple in practice. And in the report, you know, there are instances of crowded waiting rooms where just a quiet conversation, a discreet conversation could have made a big difference, expressing professional curiosity and empathy, not making somebody repeat painful information when actually there's a way around that. So it can be really simple. That would be my first thought. My second thought would be about seeing the whole person, understanding, as I've just mentioned, that somebody's disability, race, sexuality, also their life history has brought them to where they are when they stand in front of you as a practitioner, when they join any kind of part of the health service, and that all of those things are part of why somebody is there on that day. And thinking about somebody as a whole person rather than just composite parts can be a real kind of trigger point for protective potential for somebody, so that their future health and well-being and safety is really well looked after. And then finally, we are obviously going to touch on some quite big systemic and protracted problems in the system. And so there is systemic things, strategic things here, as well as things around kind of operations and practice. But I hope within all of this that we can kind of galvanize each other, share really good practice, share our motivation to make this a really fantastic part of somebody's experience rather than something that doesn't work for them. So I will leave you with that thought. We've got loads to get through this morning, so I'm not going to talk for any longer. I will be back to chair the Q&A a little bit later on, but I hope you have a great session. Thank you again for joining us. Thanks to everyone who's contributed. And I'm going to hand over to
Thank you, Suzanne, and thank you to everyone for attending today's event. Thanks also to Suzanne, Jess, Verona, and the entire team at SafeLives for conducting this important research and for centering survivors' voices in the process. Very grateful for the opportunity they've given me to speak to you today. And I'm also eternally grateful to my fellow survivors who bravely shared their experiences in hopes of changing the healthcare response for others. Your stories were heartbreaking and often all too relatable. As they have already done, I'm also here to share my story, so here it goes. As a queer disabled migrant survivor of domestic abuse and sexual violence, I encountered horrific treatment at the hands of my former partner. He was physically, psychologically, emotionally, sexually, and financially abusive for years, the effects of which I'm still dealing with today. Following years of complex and costly immigration requirements, I finally arrived in the UK on a spousal visa in 2017. However, by the end of 2018, my marriage had broken down and I disclosed the abuse I'd experienced to my GP in the same month. I presented with several trauma-related symptoms, including recurring nightmares, hypervigilance in public spaces, and excessive weight loss. The first GP I saw was an older locum male GP, and I therefore felt uncomfortable disclosing the details of the sexual abuse I'd experienced. As a result, I wasn't able to tell my whole story at the time and was unable to receive the full breadth of the treatment I was so desperately seeking. Furthermore, the locum GP was unhelpful, did not seem to understand my trauma or experiences, and was not aware of the implications of my immigration status and the limited services I was entitled to receive. Rather than making any referrals to specialist organizations, he prescribed me sleeping tablets and sent me on my way. After relocating to another borough, I needed to transfer my medical records to my new practice. In addition, I required documented proof of my previous appointments and associated assessments to present to the Home Office in conjunction with my application for indefinite leave to remain as a victim of domestic violence. When I sought this documentation, my GP informed me that I would need to physically return to the surgery, which was dangerously close to the perpetrator's home and workplace, and pay a £15 fee in order to obtain a letter in support of my application. Though I expressed concerns regarding safety and expenses at the time, my GP did not make any concessions and instead restated his position. Nor did the receptionist offer any assistance. Instead, she repeatedly attempted to cancel the appointment at the last minute while I was already en route, despite the fact that I had informed her that I had taken time off work to attend and was incurring significant additional transport costs in the process. When I arrived at the surgery, the receptionist insisted that I pay for the letter in cash as opposed to card payment, which had not been communicated previously. The receptionist repeatedly suggested that I utilize a cash machine down the road, which, due to its proximity to the perpetrator, would have put my safety at risk. Despite my best efforts to articulate these risks, the receptionist was entirely unsympathetic to the trauma that I was experiencing. As a result, I found myself crying in a very public space, while the other patients in the waiting room watched in horror. Thankfully, I was able to find enough cash in the bottom of my handbag to pay the letter fee, but by then I'd been required to restate numerous intimate details of the abuse I'd suffered in front of the other patients, while visibly upset as the receptionist had refused to read the notes on my file or provide me with any degree of privacy, despite my numerous requests. After relocating, I was repeatedly turned down for GP registration in my new area as a result of having to relinquish my identity documents to the Home Office for several months whilst my immigration application was in process. Although I was very aware of the fact that GPs are required to register all patients, regardless of ID documents, every practice in my new catchment area turned me down. When I challenged them on the relevant policy, they all replied with a "computer says no" response. As a result, I spent several months without access to any medical treatment at a time when I needed it most. This felt particularly cruel and unkind, as I'd already paid for NHS access twice via national insurance contributions and the immigration health surcharge. After moving house again, I was finally able to register with a surgery near my new home, and the nurse and GP there were much more helpful. They listened to me, validated my experiences, and provided me with a longer appointment. Unfortunately, this GP soon left for another practice, and I was forced to start all over again. After my first appointment with the new male GP, it was clear to me that he had not properly read through my file. As a result, I had to go through the re-traumatizing process of recounting my story all over again. After 9 months on various waiting lists, I was finally able to access an initial therapy session. Unfortunately, the appointment was scheduled at the wrong time. The therapist refused to acknowledge or believe the existence of my pre-existing health conditions, and the session ended poorly. Several weeks later, I was grateful to be matched with an understanding therapist. Incredibly, after all the waiting, I discovered that I was only eligible for pretrial therapy. As such, I was barred from speaking about the abuse I'd experienced until the conclusion of the ongoing police investigation, or risk compromising its outcome. More than 2 years on, I'm still waiting on the outcome of the criminal investigation and have yet to receive proper treatment for the years of abuse I've experienced. My entire life has been put on hold as a result, and I'm desperate for an opportunity to begin the healing process. Throughout my interactions and engaging with healthcare professionals, it's become clear to me that the vast majority of them have not received adequate training on domestic abuse, sexual violence, or trauma-informed responses. Consequently, I've been forced to conduct my own research at length and use the knowledge I've acquired to advocate for myself. I've spent years researching the psychological and physiological effects of long-term abuse, the manifestations of trauma in the mind and body, and the varied presentations in victims. Whilst I'm certainly not an expert in this field, I know that many healthcare professionals would benefit from further training on this topic, to include information on complex PTSD, and at least reading The Body Keeps the Score by Bessel van der Kolk, a leading psychiatrist and researcher on post-traumatic stress. As trauma responses are often unique to the individual, I would echo other survivors' concerns re not being believed by professionals due to the damaging and all-pervasive myths and stereotypes surrounding the behavior of victims who've experienced abuse. I know that I've encountered this many times as well. It is clear to me at this stage that there's still a lot of work to be done. SafeLives have identified numerous barriers for victims in accessing appropriate healthcare, and I strongly agree with their calls for additional funding in this area, a joined-up approach for victims, and additional training for practitioners. It is blatantly apparent that a full-scale cultural change is necessary to include recognition of the unique obstacles faced by marginalized groups, to include people of color, the LGBTQ community, disabled victims, migrant survivors, etc. In addition, we need IVA support in every hospital, timely access to mental health services, and a commitment from the police, social services, local councils, housing programs, and the family courts to engage in a holistic response with the goal of best supporting survivors on an ongoing basis. In regards to migrant survivors like myself, practitioners must be aware of the additional barriers to fleeing abusive partners, the implications of abusers weaponizing victims' immigration status, and the very real threats of detention and deportation, which are constantly hanging over our heads. As was the case in my situation, my status in the UK was entirely dependent upon a subsisting relationship with my abuser, and he was repeatedly threatening to phone the Home Office to cancel my visa. As I had no recourse to public funds or services, I was unable to access refuge or housing support at a time when I needed it most. I was therefore forced to stay with my abuser or risk street homelessness and/or deportation, both of which were not viable options. Hostile environment policies have forced employers, landlords, schools, and healthcare providers to take on the role of amateur immigration officials or risk receiving hefty fines and/or jail time. In addition, evidence has shown that police forces in England and Wales regularly share victims' data with the Home Office when they report abuse, therefore prioritizing immigration control over women's safety. This must change. It is clear that we need to impose a data sharing firewall between the Home Office and all public services in order to protect victims. Migrant victims should also be able to access healthcare and other support without fear of retribution and should not be prevented from registering with GPs in the event that they don't have photo ID. Survivors should not be charged for obtaining vital documentation and should not be forced to turn up in person in order to do so. As indicated in the report, the destitution and domestic violence concession should be extended from 3 to 6 months and include survivors who arrived on all visa categories, not just spousal visas. And the NHS charging regime should be abolished. It is my view that the no recourse to public funds rule should be scrapped altogether in order to comply with the non-discrimination clause as outlined in Article 4.3 of the Istanbul Convention, which the UK has yet to ratify. Domestic abuse is not just a women's issue, it's everyone's problem. It's a public health issue and its effects infiltrate all areas of society. Therefore, it is incumbent upon all public and private sectors to step up, develop concrete plans to tackle it, with adequate funding to implement effective strategies going forward. In my opinion, this process should begin in the healthcare sector, as for many victims, it's their first point of disclosure. Not only do victims need to be able to count on the responses from their GPs, but they require the full support of mental health teams and specialist services in order to access vital help and turn the tide on this devastating trend. As SafeLives have said, we need a whole health approach, which requires the need to see the whole person and attend to the full spectrum of their needs. This involves not only training practitioners on domestic abuse and trauma responses, but dispelling myths and stereotypes and empowering them to ask appropriate questions in order to obtain the relevant details of the victim's experience in a manner which is not re-traumatizing, and ultimately providing survivors with the appropriate tools and resources as required to go about the process of rebuilding their lives. I'm hoping to be able to do the same in the near future. Thank you for your time. I'm going to hand it back to SafeLives, who will now discuss the findings in the report.
Thank you so much for telling us your experiences there are. My name is Jessa Sato. I am the Head of Public Affairs and Policy at SafeLives. And along with my colleague, Verona Blackford, we will be telling you about the report that we're gathered here today to discuss. Next slide, please. Just a quick bit about us. As Suzanne said, we're a UK-wide second-tier charity directed to ending domestic abuse. While we don't provide frontline services, we work very, very closely with those that do, using our data, practice expertise, and crucially survivor voice to look at the whole picture for every individual and family to get the right help at the right time. And we challenge perpetrators to change, asking, why doesn't he stop, rather than why doesn't she leave? Our strategy, launched in 2018, set out our mission to end domestic abuse, starting with early intervention before someone is harmed or harms others, then ensuring those who are exercising harm are identified and held to account, ensuring that victims and survivors, adults, teens, and children are given the support they need to get safe. And finally, ensuring survivors are able to live flourishing lives after harm's happened. Next slide, please. I want to start a report today in some context. We know that only 1 in 5 victims and survivors of domestic abuse call the police, which means the criminal justice route is not often the best place to locate referral to specialist domestic abuse services. Moreover, since the murders of Sarah Everard, Blessing Olusegun, Bieber Henry, Nicole Smallman, and so many women whose names are less well known, we know that there has been a decrease in trust of the police. For example, recent YouGov polling shows that 71% of 18 to 24-year-olds believe the police do not take sexual assault seriously enough, a sharp increase from 58% in October last year. So we know that a public health approach is increasingly being adopted to the reduction of serious violence, particularly through violence reduction units. We believe this should apply to domestic abuse, which is of course a huge part of serious violence in London and the UK. SafeLives has had a long-held interest in the difference health-based domestic abuse services can make, and we published Cry for Health in 2016. It was the first UK multi-site evaluation of hospital IDVA services, independent domestic violence advisor services, in 5 English hospitals. It found IDVA supported victims 6 months earlier in their relationship, reached those with higher substance misuse and mental health issues, plus reached more pregnant victims than those in community IDVA services. Research shows that 30% of domestic abuse starts when a victim becomes pregnant. The report from 2016 also found estimated savings of £2,000 per victim in health service use. And we've been campaigning since then to convince the government and commissioners to fund a rollout of hospital-based IDVAs. The cost of domestic abuse to the health service, according to the Home Office, equates to £2 billion per annum, 66 billion in total. That is huge compared to the relatively small amount of 15.7 million required for a minimum of 2 hospital IDVAs to cover every acute trust. Since our report, the Pathfinder project, led by Standing Together and a consortium of 4 other specialist domestic abuse organisations, has evaluated a whole health model to domestic abuse. Our report today aims to build on that. Next slide, please. So a little bit about the project itself. Whole Health London is funded by the City Bridge Trust, which is the funding arm of the City of London Corporation's charity Bridge House Estates. Its main aim is to provide survivor voice, data and evidence to continue to build the case for a whole health response to domestic abuse in London. It has 5 key aims. First, increase the knowledge and effectiveness of the evidence base for health-based domestic abuse interventions. Second, to identify gaps in provision in London and barriers to effective commissioning. Third, to bring together policymakers and commissioners from health and social care with specialist domestic abuse frontline organisations, police and other multi-agency partners. Fourth, to campaign for extra resources to fund interventions required to create the whole health approach. And finally, to ensure all the toolkits, materials and best practice which already exist are shared with commissioners and services so that they can pursue a whole health approach across London's boroughs. So what has the project found so far about domestic abuse in London? Using crime survey data, we estimate 241,000 women and 120,000 men experienced domestic abuse in the past year in London. If these figures were applied to a disease, there would be urgent action. If we look at children, we know that the Domestic Abuse Bill will be recognising children as victims in their own right for the first time, and our calculations show that 425,000 children and young people in London will have experienced domestic abuse by the time they are an adult. And also, there is no them and us, as Suzanne said at the start. We calculate that 45,000 female survivors of domestic abuse are working for the NHS just in London. About 88,000 Londoners received medical attention following partner abuse in the last 12 months. Each time, that was a key opportunity for them to get the support they needed to get safe. And alongside the huge impact on survivors and those around them, we found health service costs of domestic abuse in London equals £433 million per year. We know this poses huge pressures for other statutory services. 1 in 10 offences recorded by the Metropolitan Police involves domestic abuse. Moreover, there's been a 7.7% increase in domestic abuse incidents and a 5.1% increase in offences since the start of COVID last year. As one of SafeLives' pioneers, survivors who work closely with us, calls it, domestic abuse is an epidemic in a pandemic. I will now hand over to Verona Blackford, who is our wonderful Public Affairs and Policy Officer, who has worked on this report and will talk you through its key findings. Many thanks.
Thanks, Jess. So over 2 months, we surveyed domestic abuse survivors who had used healthcare services in the last 2 years in London. And we partnered with specialist organisations on our advisory board, including Buy and For Services, Stay Safe East, Southall Black Sisters, Gallup and Forward UK, who were able to share the survey with their service users. Stay Safe East were also able to contribute 4 guided interviews with some of the disabled survivors who they support. And in the end, 64 valid responses were analysed. In terms of the demographics of the survivor respondents, the majority of respondents identified as women, with 6% identifying as men. Just under 1/5 identified as lesbian, gay, bisexual, or preferred to self-identify their sexuality. And the respondents were more likely to be LGB than estimates suggest the general population is. Similarly, they were more likely to be disabled than the general population, with about 1/3 of survivors identifying as disabled. Survivors aged 16 to 34 were underrepresented in the responses in comparison with the age profile of London, and Black, Asian, and racially minoritized people were also underrepresented, with 80% of respondents identifying as white, in comparison with 57% of the population of London. In the last 2 years, survivors had accessed a wide range of health services. As you can see, GPs were the most common point of access, and mental health services were also frequently used by survivors. About 1/3 of survivors had accessed A&E, while 22% had accessed health visiting services or CAMS. Nearly 2/3 of survivors said there were children under the age of 18 in the household at the time of the abuse, and almost half of those children were under 7 at the time of the abuse. Over 1/3 of survivors noted that they'd been pregnant when they experienced abuse. And as Jess said, the domestic abuse bill currently going through Parliament will enshrine in law that children are victims of domestic abuse rather than witnesses. We asked survivors what form or forms plural of abuse that they had experienced, and almost all had been manipulated psychologically and/or experienced emotional or psychological abuse. As you can see by the percentages, many of the survivors will have experienced more than one type of abuse. In fact, out of 11 types of harm that we asked about, over 3/4 had experienced 6 or more types, and nearly 1/3 had experienced 8 or more in the last 2 years. Nearly 3/4 of survivors also reported being physically harmed, and as you can see, 68% of survivors were prevented from accessing help. With regards to survivors' experiences at the health services they accessed, we separated out the survivors who knew they were experiencing abuse when they accessed health services from those who didn't know or were unsure. Of those who were unaware or unsure, over 3/4 weren't asked about how things were at home, and this represents a missed opportunity to help survivors recognise their situation and access support. Asking whether everything's okay at home can be a much more open question than specifically asking about domestic abuse, due to differences in the language that resonates with survivors of different ages or backgrounds. We also heard about a lack of join-up between services. Sorry, I'm on the wrong slide. There we go. As you can see, one survivor was told at A&E that we only do bones here, not that relationship mental health stuff, which we've used for the title of this report. If, for example, you went to A&E with a broken bone and the doctor found a tumour in your x-ray, they wouldn't send you away without first referring you to an oncologist. And the same needs to happen when survivors of domestic abuse present in healthcare settings. One survivor told us about presenting at A&E after overdosing on drugs and alcohol, calling it a cry for help that went unanswered. One survivor felt that they had to self-refer on in order to gain the support they needed, which they found overwhelming when added to everything else that they were experiencing. Lack of join-up can also mean survivors have to retell their stories again and again, and that can have a re-traumatizing effect, especially when people aren't sure if they're going to be believed or supported once they have disclosed abuse. Survivors told us about a lack of understanding from healthcare professionals around their experience of domestic abuse. As we saw on the last slide, one was asked, "Why didn't you just leave?" despite the danger posed to victims of domestic abuse when they attempt to leave the perpetrator or after separation. Other survivors highlighted that health professionals were happier to prescribe medication than look into the reasons behind the issues they were presenting with. We heard from some survivors that when they accessed healthcare services, they received treatment for the health issues they presented with, but those issues weren't seen as symptoms of the abuse, even though in their responses, the survivors identified their health issues as direct results of the abuse. And this goes against the guidance issued by the National Institute for Clinical Excellence in 2014. So we undertook a mapping exercise of the boroughs of London. In the report, we've discussed ways in which London is already a leader in health-based domestic abuse innovation. And the three types of provision that we looked at were IRIS programs in GP surgeries, which you'll hear more about later from Medina, IDVAs co-located in hospital settings, and IDVAs co-located in mental health trusts. As you can see, pink indicates survivors in the borough have access to all three, blue means they can access 2 types, purple 1 type, and grey shows where we've been unable to identify any health-based domestic abuse provision. We found IRIS programs currently running in 16 out of 32 boroughs and identified 19 hospital-based IDVAs working with adult survivors of domestic abuse, practicing across 13 of London's 18 acute trusts. This represents 1/3 of the minimum of 36 health-based IDVAs that we would recommend for a safe service. Finally, we found 3.4 full-time equivalent IDVAs practicing in 3 out of 10 mental health trusts, compared with the minimum of 20 that we would recommend. Only Islington and Kensington and Chelsea have access to all 3 forms of provision across acute, primary, and mental health care. Currently, there are spots in the capital where there is simply no health-based provision at all, and other areas where provision requires expansion to meet the needs of victims accessing different healthcare services. For example, we've been unable to identify specific provision serving boroughs including Bexley, Harrow, Havering, Hillingdon, Merton, Newham, Redbridge, and Richmond. Of course, victims of abuse will access some services outside of their borough, particularly when it comes to acute care. Chelsea and Westminster's IDVA service receives referrals for survivors resident in 26 of the 32 London boroughs. However, what you can see is that a survivor presenting in a healthcare setting in Kensington is more likely to receive the joined up care and specialised support they need than a survivor presenting in Richmond, just 1 borough away. I'll hand you back over to Jess now to look at the barriers to a whole health approach.
Thank you, Verona. So we held 2 roundtables with representatives from frontline domestic abuse organisations, commissioners, academics and other stakeholders, and we found 3 key barriers. The first was unsurprisingly a lack of long-term sustainable funding. While we know that a strong evidence base exists for interventions such as health-based IDVAs and IRIS, which Medina will speak to later, these interventions are often not funded. London is a leader in health-based domestic abuse commissioning, with welcome multi-year funding provided by MOPAC for hospital-based IDVA provision, and through a recent £1 million boost for IRIS in primary care settings. But many services still have to battle with 1-year funding rounds. This constant cycle of rebidding for funding puts pressure on capacity and prevents services from being able to roll out their services further to new areas. We know that losing funding can impact on those clinicians' trust, who are usually hugely positive about the service, but they may conclude that the withdrawal of funding is a reflection on the service itself, rather than pressures commissioners may face. Next slide, please. The second key finding from our roundtables was a lack of integration of health and domestic abuse commissioning. While London is definitely doing this better than most areas, we heard that the uplift in MOPAC's funding for hospital-based services did not always dovetail with local commissioning of community-based IDVA services, and that health commissioners were often not around the table contributing funding or to the strategy for that funding. And even though there has clearly been a big improvement in the commissioning of services in acute and primary care in London, Mental health is still far behind, and other health settings such as CAMS or community midwifery are not in scope. Finally, dentists, pharmacies, and new social prescribing networks are thought to present interesting new opportunities for stronger referral routes into specialist services. Next slide, please. Third, as we already heard from survivor feedback, a key barrier to commissioning a whole health response is the lack of knowledge in general about domestic abuse and the impact it has on the whole family, adults, teenagers, children, and of course, perpetrators of abuse. Over 1/3 of survivors' comments noted that health professionals did not appear to understand the dynamics of domestic abuse. Coercive controlling behaviour is still often ignored or downplayed, even when our survey results showed that survivors who experience non-physical abuse experience it for longer than those who experience both physical and non-physical abuse. The survivor who told us their GP asked them why they didn't just leave is not alone in their experience. And importantly, there is a lack of understanding of intersectionality and the needs of LGBT+, Black, Asian and minoritized, migrant, deaf and disabled, and older and younger victims in particular. Next slide, please. So we quickly move to recommendations, and the first is for London's Commissioners of Domestic Abuse Services. We recommend that MOPAC, the Violence Reduction Unit, NHS London, including the new integrated care services, plus London's boroughs, should collaborate on a 5-year strategy to ensure a whole health approach to domestic abuse across London.
Jess, to interrupt. I don't think Sandy can see me, just to swap interpreters. Oh,
no
okay,
worries.
Sorry.
I'll pause.
Thank you.
Can you see me now? Okay. So we estimate that funding for 36 acute trust IDVAs at a minimum would cost 1.8 million. 1 million is required for mental health trusts and 2.5 million for IRIS programmes to extend to new boroughs. That equals around 5.5 million per year, which we think is the minimum requirement to cover the 3 main health settings across the whole of London. This is small when you compare it to the 433 million cost of domestic abuse to the health service in London. Domestic abuse coordinators are also integral to an effective whole health approach, but we haven't costed them in this project. The strategy must recognise the intersectional needs of victims, including Black, Asian and racially minoritised, migrant victims, LGBT+, and disabled and deaf victims too. Next slide, please. Last, we look at the recommendations for the Westminster government. In 2019, a commitment was made by NHS England to give access to IDVAs across the health service as part of the government's response to the initial committee which scrutinised the domestic abuse bill. We believe this commitment should be honoured alongside the sustainable multi-year funding required. The domestic abuse bill will receive royal assent, we hope soon, and making good on this pledge, which would help to ensure that health plays its full part in transforming the response to domestic abuse. Given the huge impact of domestic abuse on survivors' mental health, particularly in the last year due to COVID, we would like to see the government commit to shorter waiting times for victims of trauma to access mental health support, alongside a new strategy for improving the health victims of trauma, including domestic abuse survivors. We also hope that the new serious violence bill will ensure domestic abuse is considered to be part of a serious violence reduction duty. And in response to the clear testimony we heard from Survivor R and organisations such as Southall Black Sisters, who will speak later, we advocate that the domestic violence rule and DDVC is extended to all migrant survivors, while migrant survivors in themselves should be considered exceptions to the current NHS charging regime. Finally, as SafeLives has been arguing alongside with Bernardo's, Action for Children and Violence Against Women and many others through the process of the domestic abuse bill, we would like to see a new statutory duty on police and crime commissioners, local authorities and CCGs, plus a replacement ICSs, to commission specialist community-based domestic abuse services, which would help to ensure provision for the whole family, all adults, teenagers and child victims of domestic abuse, alongside the necessary provision for perpetrators to help keep families safe sooner. Next slide, please. Thank you so much for attending and listening, and we look forward to questions in the panel at the end. I'll now hand over to Medina Johnson, the Chief Exec of IRIS-I.
Thank you, Jess. Good morning, everyone. First of all, thank you so much for involving me in this. I was part of the advisory board, and I'm thrilled to be part of the event today to launch this really, really important research and report. And I really want to sort of shout out to SafeLives how remarkable it is, how fast this has been conducted, put together, all those interviews, and you know, in the middle of the chaos that we've all been living in. So absolutely hats off, it's such important work. And again, thank you for having me. Next slide, please. So as I say, I'm Medina Johnson and I'm Chief Executive of IRIS-I. We're a small not-for-profit social enterprise. Our vision and mission are here. And our core reason for being is to promote a world in which gender-based violence is consistently recognised and addressed as a health issue. And to do that, our mission is to ensure that it's a partnership approach with specialist third sector violence against women and girls services working in partnership with health. This is something that we've been doing since 2007, when we didn't exist as an organisation, but some of the team that continue to work at IRIS-I have been involved since 2007. We launched some research, which I'll talk about in a moment. And our premise has always been, as you've heard previous speakers say, that this response to gender-based violence, violence against women and girls, has to be collaborative. It doesn't only sit with health, it doesn't only sit with the specialist third sector, it has to be a partnership. Next slide, please. Thank you. This won't come as a surprise to the majority of those of us participating in the session this morning. We've already heard how post-traumatic stress, our survivor who talked a short while ago talked about flashbacks, talked about the issues that she'd experienced in primary care in terms of expressing how she was feeling, and the response that she got was medicate, medicate, medicate. And we've been working very hard with our healthcare partners to remind them that sometimes listening, hearing, validating is a lot of doing. Doing isn't always giving a prescription. Doing is listening, hearing, and validating. Next slide, please. I'd like to spend a moment just talking about IRIS, Identification and Referral to Improve Safety, our flagship programme. And this is something that we tested in a randomised controlled trial between 2007 and 2010 in 2 sites. And one of those sites was Hackney in London, the other was Bristol. And what we wanted to test was, will a general practice-based domestic violence and abuse training and referral programme make a difference for clinicians in the way that they recognise and ask about domestic violence and abuse? And will it make a difference for patients in feeling that they are being asked, heard, and offered appropriate referral into specialist support? The second point there is our sort of mantra, if you like, the 5 key things that in any work we do, we want anyone we speak with to leave the conversation having understood and heard. We want our healthcare partners to recognise when a patient's affected by violence and abuse, know how to ask about it and conduct a high-level risk check. Nothing as detailed as the dash, because that's why we refer into our specialist supporters, our specialist workers. As I said before, give a validating, understanding and supportive response, offer a referral, and then make a record in the patient medical record. So those are the 5 key things that we promote as our best practice within general practice and primary care. The reason that I flag this is today we're talking about a whole health approach, and Jess referenced the Pathfinder project, which IRIS-I was part of. And this looked across the whole health economy as this important work is doing. And I think this very simple 5-step approach isn't rocket science, it isn't complicated, and it is something that across the healthcare sector we can perhaps promote and seek to endorse so that wherever a patient is seen, she's getting the same support, that it's trauma informed, it has the patient at the centre, and it links up patient experiences. Again, to repeat what other speakers have said, we can't be re-traumatizing people who are already traumatized by the experiences they've had. We need to be supporting our healthcare colleagues and working with them to make sure that at every point in healthcare, records are kept and that those records are shared as appropriate so that patients don't have to repeat their story again and again. And we need to make sure that medical records link up as well. Because we know then that that leads to the next three things on the slide here. We know that more patients are identified, referred into specialist support, which we know is helpful and crucial. We know it improves clinical practice. And most importantly, we know that it improves the quality of life for patients. Next slide, please. This again is a summary of the IRIS programme, and I'm not going to go through it in detail, and apologies, it's quite a busy slide. But you can see with some very simple inputs in terms of training, a care pathway, some added capacity in terms of people on the ground, the advocate educator, specialist worker, the clinical lead, a local clinician who is an advocate, supporter and mouthpiece for why this work is important, and a way of clinically inquiring and validating. With all of these things in place, again, across any area of healthcare, we know that it leads for positive outputs and most importantly, positive outcomes for patients, for primary care professionals, and for the whole practice. We heard how traumatizing and difficult it was for our survivor who spoke at the beginning of this session to be having to tell her story in a very public place, in a waiting room, receptionists not understanding what they were hearing and not being understanding and supportive of the help that patient needed at that time. What we also promote is that any training and any interventions in health are across the whole of that health setting. So what we promote with IRIS is not only training for clinical professionals, but also for reception, administration, and ancillary staff. And again, I think when we're looking at a whole health model, we need to think about that in every single health setting that we're working in. The people on the front desk in A&E need to have understanding, information, and training about domestic abuse. Similarly, in community mental health services, in hospital desks for acute hospital services, we need to be training the whole healthcare family in every healthcare setting where we're working. Next slide, please. We've been working to promote and improve the healthcare response, as I say, since 2007, when we started our research. And from 2010, in earnest, when the research had positive results, and we were able to reach out to communities to see if people would commission the work that we had evidence base for. It says the IRIS network today. It's actually today exactly a year ago. This is our data from and up to the 31st of March 2020. We know then that in the last year we will have many more patients referred, many more trained practices, and we know that in total our network of clinical leads and advocate educators is now in excess of 160. We're currently working in 39 sites, and if you ask me tomorrow, unfortunately that might drop, because as we've heard from previous speakers, all funding around the work that we do, as well as our colleagues in other areas of health, isn't core funding, it isn't repeat funding, and it isn't sustained funding. I asked a colleague who leads on our programs in London, IRIS programs in London yesterday, whether we were still waiting for confirmation of funding for the new financial year that begins tomorrow. And yes, 2 of our programs in London, we are still waiting for that funding. An additional 5 only heard within the last month or so that those are being sustained. So while we know that our evidence-based practice works, we know that clinicians are better supported, and most importantly, patients are better supported to get the support and the advocacy that they need. all of this is very much balanced on a knife edge of funding and commissioning cycles. Next slide, please. I'd really just like to spend a moment drawing your attention to the right-hand block here for commissioners, policymakers, and decision makers. Not to blame you or call you out or in any way shame, but to really say, this is where we need your help. We know what patients want. We know that clinicians want to better support patients. So how can we work with you within the system to make sure that we can improve this? How can we coordinate commissioning strategies? Reduce the use of resources, not only in primary care, but across the whole healthcare economy to make sure that we're getting best value, not replicating, not reinventing the wheel. And how can we increase opportunities to share good practice and learn with other areas, which is what I think is so exciting about the work that's happening as part of Whole Health London today. Next slide, please. And this is really my equivalent to the wonderful title of the report that we're talking about today. You know, and I say wonderful, slightly tongue-in-cheek, you know, it's not okay that patients are being told we only do bones here. Just like I was reminded when I was putting some slides together for today, when I ran some training, gosh, 14 years ago now, in one of the first IRIS practices, and I was talking about the health impacts of domestic violence and abuse. And a clinician, slightly puzzled and slightly argumentatively said, but I know what to do when a patient comes in and she's depressed. I know what I ask, I know what I prescribe, I know what I do as the next step follow-up. And now you're asking me to do something different. And my response was, you know, equally argumentatively back, I suppose, in those days. Well, yes, I am asking you to do something different and additional, because what you're doing at the moment isn't working and it isn't serving the patient's needs. And it isn't best offering the support that will better support your patient to access support and to improve her health in the long run. So yes, we are challenging and we are asking things to be done in a different way. Next slide, please. So this slide and the next slide hopefully gives some hope and positive feedback from the work that we've been doing over the last few years. And these quotes here are actually from survivors who have accessed the IRIS service in London. I'll just give you a moment to look through and then to pull out some key things here. Our first survivor is saying the link between health and the specialist sector is incredible. The second survivor is saying that this has made a real difference to her life and future, having a health response in tandem with a specialist third sector provider. Third one goes a little further and says that having a specialist worker embedded in healthcare is like having an extension of her GP. And again, we know that this would be the same across other healthcare settings. And the final survivor sums this up in a very whole way, saying that both her physical and mental health have improved. She visits her healthcare provider less, and that her child is also safer. And yet we know we're missing people. Jess talked a little while ago about needing to recognise difference and diversity and intersectionality. And we know from our data that we're missing people. And what we need to understand is, are people with different characteristics not accessing healthcare providers? If they are they not being seen as people who might be being affected by violence and abuse? If they are, and they're asked, are they not disclosing? And if not, why not? And if they do disclose, they then feel that the referrals that they're being offered are not appropriate. And these are things that, again, we want to seek to understand more. Just before I finish up, here are some words from clinicians about the impact that having a training on referral route can make. We know that our clinical colleagues want to do more. We know that they want practical things to do, to be able to better support patients. And we know that it needs to be easy, that final comment sums it all up. Simple concept, easy to do, big impact, and that's what we all need to be striving to do. I'm not going to go through all of this information now, I'm just aware of time. If we move on again, please. And just a moment to reflect on the costs. We constantly hear, why do we have to pay for these services? It's expensive. And when we break down the it, we need to think about the capacity that we're adding. As I said a moment ago, we need to be not relying on third sector services to provide the follow-up and the support for this without investing in those services and adding capacity. This really summarises and speaks to Jess's point earlier about spending to save. So we know how much violence and abuse costs the health service, and we know how much investment in evidence-based practice costs. And the two are very different. We don't need to invest very much to actually save a lot. Next slide, please. Here's a summary of the work that we are doing in London at the moment and have been doing for some while. As I say, we're running with 16 sites at the moment, half of London boroughs. We know that in the areas of London where we've been running for over 2 years and did some work on effectiveness, that areas with IRIS are 30 times more likely to see referrals for patients affected than boroughs that don't. And what we want to see is some cross-capital commissioning and funding. We want to see this growing not only in primary care and general practice, but across those other areas, as Jess highlighted, where there's opportunity, excuse me, sexual health, pharmacy, dentistry, and so on. Next slide, please. Excuse me. And you can see that the growth here has been quite small. What we want is more and faster. You know, we're getting impatient. We want to see the whole health approach adopted as soon as possible, because what we know from the modelling that we've done is if we grow at the rate that we've grown, not only in London, across England, Wales and the other areas where we work, it's going to be another 60 years before all patients in England and Wales have access to IRIS. And it won't be that different in terms of hospital-based IDVAs, mental health services and so on. And I think we need to really ask ourselves, is that good enough? Is that good enough for us, for our families, our friends, and everyone affected by violence and abuse? And the final slide, please. Oh, next one, please. Thank you for having me. Please do come back to me if you have any specific questions about IRIS and IRIS-I and our work in London. And I'd like to now hand over to Meena Patel from Southall Black Sisters, who's going to talk about migrant survivors' experiences.
Hi, thank you. Thank you for inviting us here to speak, and the survivor's story about her access to services, particularly by the GP, is one of the things that we see again and again. But thank you for sharing that story, and we know that how difficult it is often to talk about or go backwards in talking about how you've been treated as a migrant person in the UK. Today, what I'm going to do is talk about some of the challenges of that Southall Black Sisters face in terms of services and provisions for migrant women in particular. And so we face a lot of, the Southall Black Sisters face a lot of struggles waged by Black and minority women for equality, justice, against the backdrop of immigration controls, racism and regressive politics in the UK. And we see that quite constantly recently with Priti Patel, who's bringing out more and more rigid immigration systems and laws that affect our most vulnerable people in society, which is women and children in the UK, and particularly migrant women. So I don't want to take up a lot of time to talk about what Southall Black Sisters, but just to say that we were established in 1979 in the backdrop of an anti-racist movement. We're a feminist organization, and we set up the first Black Women's Centre in 1982. So we are a frontline advocacy and campaigning centre for Black and minority women. And the reason why we set up in that specific way at that time was that partly because of the fact that a lot of Black and minority women who often access statutory services were turned away, and no help was given, particularly when they were subjected to violence and abuse. They were told that they had to return back to their families and use their own cultural mechanisms in order to resolve their problems. And so we felt that it was really important that those women were provided the same support as every other woman in the UK. And so as I said, we have a frontline service that deals with domestic violence, and we feel that's also important to have hand in hand longer term changes, because many of the women aren't able to access our services. So we felt that other services need to provide an adequate service that protects victims, in particular Black and minority women, in terms of domestic violence. So we campaign and make long-term changes. Over the years, we've made many changes around immigration law and the domestic violence law, forced marriage, the criminal system in terms of women who kill violent husbands. So over the years, we've made very large changes to the system, as well as smaller changes more locally. In the time that I have, I'm only going to highlight a few of the key challenges that face South or Black sisters in an attempt to support women with insecure immigration status, and also face gender-based violence. In doing so, we seek to stay true to our principles, which is to build more inclusive, progressive politics based on ethics and care and compassion, equality and respect for humanity and human rights, a politics that leaves no one behind. For us, it's really, really important that our principles remain there and are very strong. We are living in a tumultuous times, characterized not only by the rise of racism, but also with austerity and resurgence of nationalism and religious and fundamentalism. All of these developments have deepened inequality, widened the imbalance of power between state and its citizens. They have created a climate of fear, division, and regression. So much so that we are in danger of turning our backs on our common humanity and on the universal values of human rights that are established in the aftermath of the Second World War by struggles waged by ordinary people around the world. What events throughout the world have shown is the darker and more sinister politics of hatred. Intolerance and violence is threatening to become the dominant mode through which we relate with one another. It is driven by the fear of the other and holds sway as we experience the retreat of welfare state, the consolidation of market values, the power symbolized by, amongst other things, declining wages, cutbacks in public services. Perhaps most and more than anything else is the enactment of draconian immigration policies that highlighted just how susceptible the political landscape has been in scaremongering, in which immigration has mercilessly been used to gain votes. Economic uncertainty and manipulation of people's fears and anxieties about migration and minorities was always going to be a toxic mix. And so it has proved to be, it is an ordinary and a toxic mix, so it has proved to be, but it's an ordinary and powerless people, especially from severely marginalized groups. We are reaping the results of the state policy of creating a hostile environment that has seen the rise in race, hate crimes, and made racism acceptable. And we see that a lot more now. And it's become very much within society that racism is acceptable. And I saw that a few years back when a woman with a full burqa was on the bus, and somebody jumped in and called her a terrorist. So we can see how racism across everywhere is acceptable in public society. And we know that we are experiencing a new and uncharted chapter in immigration and immigration enforcement in the UK as the rest of Europe. We are seeing the merging of external and internal border controls that make society to turn in on itself. Internal border controls are cutting through communities and undermining any attempt to create welcoming civic spaces based on equality, compassion, shared experience, and humanitarian assistance and care. This development, when taken together with austerity measures, especially the withdrawal of legal aid, so necessary to challenge immigration abuses of power, has left groups like South All Black Sisters reeling on many fronts in respect to trying to support and assist vulnerable migrant women and children who need to assert their right to protection, human dignity, and security. Our work with migrant women has become increasingly difficult in an anti-immigration environment. At least 60% or more of the women that we see have been subject to gender-based violence and have insecure immigration status. We've spent over 3 decades trying to assist them to obtain a right to stay in the UK as victims of domestic violence and to access key services. Just when we have made some headway, we are hit with a wider tsunami of immigration policy imperatives that have a number of serious consequences for women that we serve, as well as other migrant groups. Another examples we are concerned about is the extensive powers given to landlords in the Immigration Act 2016 to carry out immigration checks. It'll create a culture of impunity for unscrupulous landlords to harass and further disempower further vulnerable tenants, many of whom, like ours users, have fled domestic violence and terror in their home. We are anxious too about the government attempts to refuse healthcare to migrants. We are also worried about the government's intention to collect data on nationality and country of birth on all pupils through a school consensus, which is likely to be used for immigration control and purposes. One example I wanted to give today was very recently, about 4 weeks ago, one of our clients who had an immigration, who was a migrant in the country, had immigration issues, passed away as a result of cancer. She had been in the country for 20 years with her husband, who brought her over as a dependent. And she was subjected to violence and abuse throughout her life, both in Nigeria and in the UK by her husband. He then abandons her, leaving her all alone, not knowing what her immigration status is in the UK. She spent 20 years trying to apply for asylum and get the government to recognise her fears if she's returned back to Nigeria and what she was subjected to in the UK. She was again and again refused the right to remain in the UK, stating that she can return to other parts of Nigeria or other parts of the bordering countries to Nigeria and live there. She ended up in hospital about 3 weeks ago as the cancer returned back with a vengeance. And she has no family or friends in this country. And we were her only family in the UK, and her friends from our other users who'd become close friends. She went into hospital, and I tried very hard to try and see her. And I tried to say, and this isn't because of COVID restrictions or anything, this was a fact that they said to me that I wasn't her family and therefore she cannot have any visitors. I pushed and pushed and said that I am her family, I am her friend. I need to see her, I need to speak to her. I wanted to see how she was, but then they refused to let me see her because I also needed to see what she wanted to do with her personal belongings and what was going to happen to all of that. What does she want in terms of her body? But I was refused entrance. I, in the end, got so frustrated with the system that I went into the hospital and I spoke. I kind of went in and insisted I was going to see her. I am her IDVA, and therefore I have the right to see. I've worked with her for over 5 years. And I went in, I saw her, and she was, although she couldn't speak, but her face had lit up, seeing me there. And she recognized me. I can't tell you what she looked like, but I was horrified because at first I didn't believe it was our client and had to leave the room because I just felt it was very difficult for me actually to see her in that way. Then she gets discharged and put in a nursing home. And again, I tried to insist that if I could see her, because I was her IDVA, I was working with her. I was also her counsellor at one point as well. But they refused. They said the only people that could see her was her family, and she has no family. In the end, on the Saturday, she passed away on the 8th of March. On the Saturday night till 8 o'clock, I kept ringing the nursing home and they kept fobbing me off saying that the people in charge were on the phone or in a meeting and they couldn't let me see her. And I had to get verification before I can go and see her. Sadly, she passed away at 1 o'clock in the morning on the 8th of March. What I also wanted to say was that in the hospital, when she arrived there, the first thing the practitioners there said to her was that you do realize you will have to pay for all your treatment. She immediately got on the phone and spoke to me, and she said to me, Mina, what do? I can't pay for this treatment. Shall I leave? It took me a very long time on the phone to persuade her to continue remaining there, to get better, and I will deal with the issue of the charges from the hospital. And she remained there. But it took a long time. She was in a lot of trauma. She was really worried about herself, her health, what was going to happen to her. But to be told right from the onset that you will be charged, and these are practices that we see in third world countries such as India, Africa, and we're told that you have to pay before you get any service. And it made me feel that, are you treating this woman because she's Black and because she's a migrant that you said that to her? How insensitive is it to tell somebody who's dying and at the last stages of her health to say that you're going to have to pay for your health service? So I'd like to now see how they're going to be paid for the health care that she received. This is not just a one-off case, but we see many like this, and many women who are subjected to attitude and judgment when they seek healthcare provision. We've got another woman who accidentally fell and hit her head, and she has a swelling on her head. She doesn't have much longer to live either. A migrant. She has attacks randomly every week, which results in her going into hospital to get further tests and so forth and make sure she's all right. She already has over £1 million bill that's arrived to her house, and she's worried about that. She's concerned as to how she's going to pay for that. And this shows that the extra trauma that the state presses on women who are vulnerable, and particularly on migrant women who don't have the right to remain in the UK, who don't have the access to services in the same way that other women in this country are able to have and afforded that help and the safeguarding. Those women don't have access to refugees, to any other services, and therefore that leaves them vulnerable and not approach services for the fear of being reported and deported. And we see that again and again with the way in the Immigration Act actually enforces that. And so we are really worried, because one of the things that we have done is we've kind of tried to, with the domestic violence bill, in the bill, it excludes migrant women and it doesn't take into account experiences of migrant women. We actually put recommendations in and it was presented in the House of Lords. The House of Lords have unanimously passed that the domestic violence bill should include migrant women, but we're yet to see what will happen in Houses of Parliament. We don't hold hope for this category of women to be included in the domestic violence bill. And for us, that makes us stronger. And it makes us stronger for Dorothy, who spoke eloquently, and her tenacity to fight at the Houses of Parliament, giving evidence around immigration and how migrant women such as hers are not benefited by support and help in the UK. She was an amazing woman who had become an ambassador for Southall Black Sisters, a woman who could have contributed to society in this country had she been given her right to remain. Her husband, who was a perpetrator, received his right to remain in the UK, but not her. And so we see how this continually affects migrant women in accessing services, and organizations like ours who are constantly having to fight with frontline services. One, not to be judgmental and not to question women about their status in the UK, because one of the key things they do ask is, do you have the right to remain? And posters are put up everywhere that you will be charged if you don't have the right to remain for your treatment. And certainly myself, when I went into hospital, and there's a clear example of how you are judged when you walk through with the color of your skin. I was asked whether I had the right to remain, and when I arrived into the country, which was back in 1965, do I not have the right to services? Am I judged when I walk into a hospital? So we can see how migrant women will feel approaching health services, and what use they would make of my information, and how GP surgeries actually do share data with the Home Office. Does that make me feel vulnerable in the fact that that would be shared with the Home Office and therefore subjected to further trauma of being detained and deported? And we see that quite a bit in the way the police deal with migrant women. I won't go into it in great detail, but that is one of the practices that happens with the police. Another example I'd like to give you as well with the GPs very recently, a family doctor who had written a letter for the perpetrator and said in the letter that the family, now she had left that GP, the victim had, and gone to another GP and registered there. But the family doctor wrote how the couple were a very loving couple, respected each other and lived together very happily. And it was wrong for the in this case, he called her a perpetrator, that she should behave in this manner and so forth. This letter was so judgmental against the victim, even though he didn't know her. How do you assess whether the couple was loving when you haven't even spoken to each of them to ask them whether the family, how things were in the home and things? In the end, this letter was given to the judge. The doctor actually got a condemning response by the judge and said that in his view, he was not going to use the letter to make his decision. And this was in the family courts. And that it was so judgmental that that the doctor could not have made the assumptions that he had made. So this clearly shows how there has to be far more training with GP surgeries and their reaction to victims of domestic violence, and not to write such letters without knowing the full facts of the case. And it's not their role to do that either. Their role is to protect and safeguard. That's what their role is, not to write. They're not in that place to write such letters. And that's a very clear example. And this was just about a few weeks back that this came up. So it shows how GPs and the health services have yet a long way to come one of the struggles that we have more and more of is where, yeah.
Mina, it's Suzanne. I'm so sorry to cut in, but we
Okay.
are just running
just
short
have
of time.
2 more minutes and then I'll wrap
Yeah,
up.
absolutely.
And so what we are concerned about is that particularly the male doctors, and particularly if you're from a same cultural or same community, often are judgmental, and the fear of women going to such doctors for the fear of what they say will come out in the community. I'd also like to quickly point out the 10-minute rule. One issue, 10 minutes. How do you get patients to then talk about domestic violence if that's what you're talking about every time you walk into a GP surgery? 10-minute rule. And so for us, we feel that it's really important to have this report and the launch of this report because it clearly highlights how migrant women have extra hurdles to overcome in order to get help. It is also about compulsory training. And I think it should be compulsory for everyone to have training in the NHS. We have set up in West London a training program for all the local GPs in our area, and they come to us for their training each year because they like the way in which we combine the pathways to identifying domestic violence and how you do that. And I think it's one of the best ways of now looking at how compulsory training should be given on a year-to-year basis because you have huge turnover of staff and it has to be compulsory. I'll stop there and thank you very much.
Mina, thank you so much. And I can tell there are a lot of people in the chat cheering you on and would actually love to spend the rest of the day hearing your expertise. So thank you very much for that. And you've given some incredibly powerful and very distressing examples actually of where the system is not working and actually where policies and practice, which at the moment are pulling in the opposite direction of everything that we'd like to see. So thank you to you. Thank you to all of our speakers so far this morning. And we're now going to try and bring together some of the questions that people have been asking as we've been through this morning's session. Apologies that I'm pretty sure we're not going to get to all of them because there have been quite a few. So we will try when we write round with the slides and the recording of the event to cover as many of the questions that we didn't get to as we can. But I'm just going to ask our panelists to tune in, to come back on camera where they can, and we'll try and cover some of the questions that have come in. I would say as well, thank you to all the amazing attendees who've put their best practice examples into the chat. So if people have time, scrolling through some of the best practice that is there is actually really motivating to see excuse me, some of the great things that are going on. And it is interesting to see that while we're talking about Whole Health London today, the North has shown up. So some great examples there from Wigan, from Manchester, from Blackburn and East Lancashire. So thank you to everybody who's been posting in the chat throughout. So I'm going to take a first set of questions together. And I would kind of call this, I guess, kind of practical tools and resources. So if I can ask Jess to answer the first couple. So there's a question here about from Rachel in Luton and Dunstable about being in an IDVA role, but trying to get that integrated into her local NHS system. So getting support for training, so SafeLives accredited IDVA training, also having to make the business case repeatedly, something so familiar to IDVAs who are working within a health setting. So Jess, if I can leave you to think about that for a second, I'll come back in a sec. And if you could also take a second question from GJ about what's a safe level of IDVA provision in a hospital or health setting, because we know sometimes we've got lone workers. So if you could say something about that. I'm also at the same time going to ask Medina to say whether Iris will ever be available for dentists, because that's a question that's come in. And also for Mina, whether you could say whether Southall Black Sisters take referrals from out of area where, you know, maybe bits of the country where people, you know, aren't equipped for supporting migrant survivors. I know that's something you handle a huge amount in your service and your sister services. So I wonder if we could just start with that set for Jess, Medina and Mina, and then I hope we'll squeeze in a second round as well if people can be as brief as possible with their answers. Thanks, everyone.
Okay, I'll be super brief. Thank you, Suzanne, and thank you so much, Mina. That was incredibly powerful. So in terms of how do we convince local commissioners, this is this is one of the reasons for the Whole Health London project, is to help organisations make that case. But there is a fantastic business template in the Pathfinder toolkit, which I've shared in the chat. So please do make use of that. Obviously, we've got our original reports. IRIS-I have got all of their data and evidence. But I would say get your elected representatives on board. So message your MPs, message your local councillors, those particularly involved in community safety partnerships and the Health and Wellbeing Board, and bring them on side if you're finding a little bit of difficulty there, because once you've got that local community commitment, I sometimes find it makes a big difference. In terms of GJ's question on safe provision, this is a really, really good question. We do say that single IDVA practitioners, in particularly in hospital settings, but frankly in other health settings, is not safe. What happens when they need leave, which of course they do need leave, or when they're sick? There is no service there. And we know that IDVAs who have had the sole IDVA in a hospital have said it's really funny how they're on holiday, that there's no domestic abuse survivors who come through the A&E or the maternity unit, because of course they're simply not there, not receiving those referrals. But it's more than that, because IDVAs, particularly in hospital settings, are working in a high trauma situation. They may be seeing things that you wouldn't normally see in a community-based setting. And therefore, it's ever more important that they have colleagues that they can download with, they can seek that peer-to-peer support, as well as making sure they're testing, obviously, their expertise with other colleagues and professionals who they can then get that sort of support back from. Obviously, we would always recommend that you shouldn't be practicing as an IDVA in particular without having the qualification of an IDVA. And there is sector-wide standards that govern the provision of VAUG and domestic abuse services that we would hope that all services operating would be according by. And of course, at SafeLives, we have our own Leading Lights accreditation service. So through all of those different things, we hope that that might help to create a safe practice.
Thank you, Jess. Medina. Dentists, IRIS-I?
Yeah, dentists. Yeah, thank you. Again, I'll be super brief. Yes is the short answer. We really hope so. We were part of a programme called DRIDVA, Dentistry Responding in Domestic Violence and Abuse. There's some information on the University of Bristol website. I can send some over for sharing after the event. I can see we've got colleagues from Manchester on the call, and in fact, Manchester Women's Aid at the Pankhurst Centre were part of that pilot piece of work. So it was research in 7, I think, dental practices in Manchester using an adapted IRIS model. Lots of additional things to think about, because you have a dental nurse with you when you're a dentist, so you're not on a one-to-one with the patient. Sometimes the door's left open. That approach to somebody in a dental chair, having somebody right up close to you, is additionally triggering and additionally difficult for people already affected by violence and abuse. So lots of different things to think about. Yes is the short answer, and a paper is out for peer review at the moment, just short of being published on the DRIDVA programme.
Lovely, thanks, Medina. And Mina, Southall Black Sisters' ability to take referrals from other parts of the country. We've got you on mute, unfortunately.
Yes, we do take on, we have a helpline as well, and we do take on cases outside of the area where there are no services to refer them to, but certainly we would guide them through over the phone as to the kind of actions and help that they can get. And in some cases where they haven't had any support in the area, we've ended up bringing the woman into London so we can give a holistic wraparound service. And very quickly, somebody asked about training. Just want to say that, yes, we do provide free training. Some money would be welcomed to keep our organisation going. But if you're really strapped for cash, we do provide the free training.
Thanks very much, Mina.
The GP, sorry.
And we'll put details of the Southall Black Sisters helpline into the chat so people can see it. But also, I'm sure, be on the website as well for people who want to access that and know how to use that in future. I'm just going to try, I know we're just about out of time. I'm just going to squeeze in one last round of questions for anybody who can stay with us just a little bit longer. I can see We've still got 234 participants. So people are still keen to hear it. So a few questions that I kind of categorize as barriers and pitfalls, I suppose. So there's a question from Marie about GPs dismissing the issues that some of their patients are facing as cultural issues. So if they're assuming that somebody's from a particular background, and Mina just touched on it, particularly if the GP is of the same ethnicity, there may be some kind of queries there about handling that if it's a close community. But if panelists could kind of speak to that issue of GPs in particular kind of thinking of something as a cultural issue rather than as domestic abuse. Polly from the Sharon Project asked whether there's a risk if we think about a health-based approach. Is there a risk of medicalizing domestic abuse survivors? And if so, how can we create a blended approach across lots of different responses so that survivors get a really holistic level of care that they need? And then Shimona has asked about what the evidence says about so-called perfect victims, and whether that's a barrier to people getting the help they need. And perhaps on a kind of similar thread, Mark from Mankind has asked, if we know that fewer men are coming forward than are actually experiencing abuse, what can we do about that? So a whole set of questions there, I think, around barriers and pitfalls in terms of people getting what they need. And I wonder if I could come to you first, Mina, and then maybe come to other members of the panel to sweep up with any final comments that you've got on that set of questions. You're on mute, Mina.
Sorry, still trying to get used to this system of working. Basically, I think medicalizing of DV, I think it's not so much of medicalizing them, but also to provide the service they need, the adequate service, someone to just talk to. And we all know that when we're victims of domestic violence, they have suffered at least 10 years of domestic violence before they even come out and speak to anyone or even speak to a GP about it. And so we need to make sure that we don't medicalize it, but we are aware in the back of our heads that some of the kind of conditions that they do have are also as a result of the internal traumas that they're going through. And that's what we need to deal with. And we need to deal with that in conjunction with the DV that they're subjected to. And one of our practices at South of Black Sisters is if you don't deal with the social issues, then it will have an impact on their mental health as well, their physical health. And what we've done, and we have our own counselling service, which isn't what the government provides, which is 6 weeks about altering people's mindset, which I think is absolutely rubbish, because that's not what this is about. This is about dealing with women's trauma. So we believe those go both hand in hand, dealing with the social issues and then having the other counselling and that will reduce the cost on the NHS with that kind of practice, because you're trying to nip it in the bud first, quickly, before it becomes acute. And we see that with our clients when they arrive to us, that the counselling is what we provide, and that actually helps them not to go into the medical services, because you're dealing with it there and then. Although with some cases you have to have medical intervention. And GPs dismissing cultural issues again and again. We thought we had progressed. Unfortunately, we haven't. With that letter, you could see straight away that we haven't progressed, particularly with the men GPs. But in this particular practice, we were able to put in a complaint because the manager works very closely with us in terms of setting up a domestic violence service in her GP and having direct access to South of Black Sisters when there is a victim. So, she's dealing with that particular doctor in terms of the complaint that we've made. I suppose it's addressing it and making sure that complaints are put in. And we do, as an organization, where things have not gone wrong, have gone very wrong, we actually do put in letters of complaint, and that will then address how the health service deals with victims of domestic violence. So it's being mindful of that. And then also thinking about, if you have a victim, to think about changing her doctor, particularly if that doctor is dealing with the perpetrator as well, or perpetrators in some of the minority communities, being mother-in-laws and father-in-laws. Yes, perfect victims often get the help, and I see that again and again in terms of at a Marat meeting I was. They said that because she showed no signs of injuries, therefore she wasn't deemed to be a domestic violence victim. So you can see that you're only a perfect victim if you have any physical injuries that are visible, as opposed to any injuries that are kind of internal or around the head that's often used, and emotional, cohesive kind of behaviors that cause issues as well. That's not recognized still, and we still have a long way to go, I'm afraid.
Mina, thank you. And any final thoughts from our other panelists? I know we're over time, but any final thoughts you'd like to give on those questions that people had? I see Medina's hand up, so I'll come to Medina and then to Jess. Thank you.
Thank you, Suzanne. Wholeheartedly agreeing with everything Mina's just said in response to those questions. And it's tantalizing, isn't it? Because there's so many other great questions coming in right now this minute. But just a couple of follow-ups from what Mina said. I think on the risk of medicalizing, we often get asked by professionals, what can we do? I think I mentioned this in my session, and I think it's creating that understanding that doing doesn't have to be prescribing. It doesn't have to be referring into another healthcare intervention. Doing is listening, hearing, and validating, and that's what we spend a lot of time doing when we're training our professional colleagues. That, you know, noticing, recognizing, hearing, and reflecting back is a lot of doing. And I think the perfect victim question, again, it's about training and encouraging our clinical colleagues to kind of remove or any scales that they may have on their eyes. We know that there isn't a perfect victim. We know that any of us and all of us can be affected, and it's creating that understanding and you know, really reminding our clinical colleagues to be professionally curious at all levels and have a low threshold for asking. And very finally, I saw Mark's question about when will IRIS be available for men. It's being tested right now. We promote evidence-based practice, and at the moment we don't have sufficient evidence to roll out a program that we know will be effective for men. It's being tested in various areas through randomized controlled trial work, again, as the original IRIS was, and that's nearing its end. So we are looking at interventions that will also support men and support children in their own right. Thanks, Suzanne.
Thanks very much, Medina. Jess.
I just very quickly wanted to answer one of the questions about what a typical victim of domestic abuse looks like. And our report does try to really make sure that health professionals and those who are commissioning services recognise that there is no typical victim of domestic abuse. Obviously, domestic abuse is disproportionately experienced by women, but within the report, there are sections that look specifically at the experiences of particularly disabled survivors, one of whom told us, supported by Stay Safe East, that they felt like a ghost in the system. So please do look at the report in terms of all of those vulnerable victims who may, for example, not necessarily be seen by services, but most definitely there. But I did want to hand over to our survivor just to talk about that aspect of not being the typical victim of domestic abuse, perhaps to finish us off, Suzanne.
Yes, please. Thank you.
Hi, Jess. Thank you so much for that. Yeah, I mean, certainly in my experience as a, disabled migrant survivor, I'm very aware of the fact that there is no typical victim, and that, certainly in my engagement with healthcare professionals and the police, other services as well, I've effectively received a lot of pushback in the context of not being perceived to be fitting within the stereotype of this, ideal image of the typical victim and how that person should act and behave in response to abuse and trauma. And I completely echo all of your statements that you said, Jess, about definitely, I feel like it's important to acknowledge the fact that there is no typical victim, that trauma can manifest in various ways, that everyone's response is different. For some people it's fight, for some people it's flight, for some people it's freeze, and that, ultimately it's dependent upon that individual and their lived experience, and that it's not upon any of us to determine what a credible victim should look like or how they should present. And I feel like that in general is an important concept for everyone to acknowledge. And thank you for asking for my input.
Thank you. And thank you once again to all of our fantastic speakers. There are so many questions and we've only really scratched the surface. So we will try our best to make sure that we round up all the questions in terms of what we send out. There's going to be a lot to send out. There'll be the recording of the event. There'll be a copy of the report, of course. There'll be all the speaker presentations. There'll be as many questions as we've managed to kind of capture. I know there've been questions about, can we do a transcript of the chat? So we'll try to do that as well, because I know there's been a lot of really valuable material there. A huge thank you to everybody who's been here with us this morning. Still nearly 200 people, even though we're over time. So thank you. I know we've covered a lot of ground where we've said a lot of what the issues are, but I hope we've also presented a whole set of motivating ways to change things as well, and that change is possible. And if we can change things, we can create so many better outcomes for people. We can find people sooner, help them get safe and well sooner, whoever they are, whatever their identity is, whatever their characteristics are. So thank you so much for being here today. We hope you'll take what you've heard and do something practical with it. There are lots of practical suggestions we've made. Do be in touch with us at SafeLives or any of the other speaker organisations if you'd like to do more in this space, whether it's around training or policy or anything you'd like. Do keep going. We know it's hard, but keep going. Thank you very much for everything this morning. Thank you to the team for all of the organisation. And we hope to see you and speak to you again soon.